Mr. Chairman, ladies and gentlemen, my topic is the transcatheter perimembranous VSD closure with devices. I think it's better to speak in English. First of all, if you look at the history of the VSD closure, it was started in 1988, but with the invention of the Alpay devices, it tended to increase in numbers. And then with the inventing of the perimembranous VSD closure after 2000, there are a lot of numbers in a lot of countries that doing transcatheter closure of the perimembranous VSDs. When we look to the first Alpay device, this is an eccentric device. The left ventricular side, the upper side is very small, 0.5 millimeter. The lower part is longer, about 5.5 millimeter, and then there is a radio-opaque marker at the bottom that should be in the bottom side of the left ventricle, and then the waist size or waist diameter is waist size or length is around 1.5 millimeter. And then if you look to the right side of the disc, there are 2 millimeters extending wings along the waist. So when it was started, then we did some patient selection criteria, the LV volume increase, and then body weight exceeding 8 kilograms, enough Spartic rim exceeding 2 millimeter. And then there are several contraindications such as supracrystal VSD or inlet VSDs. And then, as you know, many of you know this method is this is an arteriovenous loop creation, and then after creation of the loop, we put the long sheet to the left ventricle, and then we close the VSD with this device. This is one of our examples. As you see, this is a very smooth procedure in most of the cases, and then we published our results in 2008. After that time, also we have a lot of reports, but I want to mention one report that was published by Masure et al. In that report, they published their results about the 186 patients. And then when they look the groups, the first group is the single perimembranous VSD, the second one is the single aneurysmal VSD, and then the third one is the multiple aneurysmal VSD. And then the closure rates around the exceeding or changing between 90 to 89 to 90% at the beginning, but at the follow-up, the group one has been reached to 100%. But if you look to third group, the occlusion rates as the same at the latest follow-up. And then they saw some complication regarding the rhythm problems. Left anterior hemiblock in 9 patients, incomplete right bundle branch block in 7 patients. After these reports, there are a lot of concerns about the atrioventricular block with this device. The block may occur temporarily during the intervention, but most of them may resolve, and then, but permanent left anterior hemiblock may be permanent. Permanent block may occur at early or late phase. It's very worrisome complication. It is related with the catheter wire sheath device trauma to the conduction system. It is a very important cyst. It may be related with early or late permanent AV block. If you see a block during intervention, you should be worried about the late block in that patients. And if you solve this problem during the intervention, you should pull back or reposition of the catheter, and then if it recurs with unforced or appropriate catheter manipulation, consider the abandon the procedure. But if you look at European registry, which was published in 2007, they showed almost 5% of the perimembranous VSD cases may have atrioventricular block. And then most of them early, but also it may occur at the late phase of the follow-up. So this is a very bad complication because we don't know which patient will have this kind of complication. After these reports, the use of this device in European countries less than 5 years old, mostly vanished or not appropriate. And then there, when they looked to complications, they found 13 cases who needs early intervention, early surgical intervention after the VSD closure. And also when they evaluate the cases with atrioventricular block, it may occur in small kids, such as 1 year old, but also it may occur in adult patients, such as big as 55 years old. And also, most of the patients may, had some kind of perimembranous VSD, which were closed by the ambulatory perimembranous VSD device. And then most of them needed pacemaker implantation. So there are also several case reports. As you see here, this is from United Kingdom, I think. They put the device in a 15-month-old baby VSD, and then the child has collapsed, had collapsed, and then when he arrived to the hospital, they found a systolic and then received CPR, and then they urgently removed the device and then a surgical closure. So another report by Chesa and all, they reported their experience in adult patients. And then in 30 patients, they closed, in 28, they closed the perimembranous VSD with perimembranous VSD device. And then they saw complications mostly related with the arrhythmias. So because of that, after the disappearance or not regular use of the ambulatory perimembranous eccentric device, there are several reports that there were methods that can be closed to the VSD, such as this is a VSD with lung tunnel VSD that can be closed by a ADO1 device, as you see in here. As you see in here, the waist length of this device is very long, and also it doesn't have a right-sided disc, and then it may be helpful for preventing the tricuspid valve incompetence or tricuspid valve problem with this device. Actually, this is an old patient, around 30 years old with VSD. So when we look to literature, we can see some papers that they describe the VSD closure with other devices, such as ambulatory ductal occluder 1, vascular plugs, or muscular VSD occluding devices. This is a report which came from United States. And then they close these defects with ventricular septal aneurysm with these devices. And then they found very successful closure rates, and then they didn't see so much residual chance and rhythm problems. Also, there are another report. They only used the ADO1 device, which came from Korea. And then, as you see in here, all of the defects has been closed by the ADO1 device. And then, as you see in here, there are very less trivial leak, cable fracture, and transient AV block, and then moderate leakage, hemolysis, and trivial leak. And then they found a very low complication rate, and in the long term, they don't see so much block rates. But also, we can use other devices. This is although a small defect, which was closed by 6 years ago, with ADO2 device. This is another device that we can close the VSDs safely, but it should be smaller defects. As you see here. But this is a relatively small defect, I should confess with that. So it's complete closure. Also, there are a report by the German group. They closed the 31 defects, septal defects with unplacer duct occluder. Success rate is around 94%. In one person, because of the device malalignment, they have to be explanted the device. In one of them, the device was embolized to the right ventricle. The device interventionally retrieved, but the surgical closure was performed. During 41 months of follow-up, one patient had atrioventricular rhythm. It means, I think, it's a kind of junctional rhythm after 24-hour post-implantation time, but these resolved spontaneously. They don't see any much more rhythm problems. So, in conclusion, they say ventricular septal defects in selected patients may be closed by AD01, AD02 device as an off-label therapy. It appears this device may be preferable for the moderate size defects, such as between 2 and 5 millimeter, especially in infants and small children, because it is better profile and trackability. The incidence of the complications is acceptably low, and then it is possible superiority in terms of less AV block development needs to be proved with longer follow-up periods. So we don't know the much more time about this device. Because of the failings of the first unplacer device, the second unplacer device has been developed to overcome the AV block problem. In this new regulation, new device, this is the first device, this is the second device. There is a 75% reduction in the radial force and 45% reduction in the clamping force. And then they put some measurements to increase the stability. If you look the details, the left disc elliptical and concave shape helps adapts to LVOT and provides improved tension and stability. And there are two types. The eccentric one is there is 1 millimeter superior rim and 3 millimeter inferior rim. Concentric device looks like a muscular VSD device, but it's somewhat different. There are 3 millimeter exceeding rims at the waist. If there is a more than 3 millimeter distance between the defect and then the aortic valve, then this device can be used. There is dual layer configuration. There is thin external layer imparting minimal radial pressure, while the inner portion provides stability. Base length increased from 1.5 to 3 millimeter, and then it may reduce the clamp force against the ventricular septum. Both versions of the device are available in 9 waist diameters from 9 to 10 in 1 millimeter increments and plus 12 and 40 millimeter. And then there is a new torque wheel system. As you see here, this is the outer part. Maybe you see this is a thin layer of the waist, and then this is the inner parts. It can be seen radiographically. And then Tisikas and friends published their reports, and then they closed the VSD in 19 patients, and then the smallest patient age is 1.4 years, and then weight is the 9.3 kilograms. And then they found successfully closed this defect. If you look to long-term follow-up, there is a trivial leak, only a small percentage of the patients at the latest follow-up. There is one procedural complication, but in this multi-center experience, the device implantation was feasible, safe, and effective, with no more than mild residual shunting on follow-up. No patient experienced any degree of AV block or nuanced complete bundle branch block at 1 year follow-up. These initial favorable findings suggest that further studies should be pursued. Large multi-center studies with even longer follow-up are required to validate the extent these initial results before widespread use. So, in conclusion, permembrane VSD closure in these patients may be alternative to surgery in this patient group. There are several devices for this closure methodology. The most important issue has been the AV conduction problems. There are research to eliminate this worrisome complication in many ways. Perfect device for permanent VSD closure, unplacer permanent VSD closure devices, coils, ADO1 or 2 vascular plugs may be used in this treatment methodology. So thank you for your attention.